Okay, good afternoon. Can't see anyone, so could the board members please say their names if they're here? Just I see Tom, I see Jess.
Sarah Teachout's here.
We have Dr. Merman. Oh, no, I think we're going to start without him. Okay. And do we have
you were starting with me? Are you starting with CVMC?
we can start with you, and then we have minutes, and then we'll move to CVMC.
Okay.
And do we have a court reporter today? Abby, are you on?
Chair Foster, this is Susan. I know we have a court reporter. We've been corresponding with them this morning. I will confirm with Abby. Hold
Okay.
1 minute, please.
Okay, why don't we just give it a minute?
Claudine, are you here? I see her here.
Why don't you just give her a call, Abby, and check to see if she's all set up and she can
Yeah, I'm
let
just
us know.
texting her. Just got a text right now, so I'm gonna call her again. Claudine, can you hear me?
Good morning, this is Claudine. I cannot hear you guys.
I hear an echo and I see that you're joined on your email account.
You're coming across now. I'm connected by 2 ways, so that's the echo. I'm sorry. I'm going back on
That's
mute,
okay.
but I'm ready when you are.
Thank you.
Great. Okay. Claudine, my name's Owen Foster. I'll run the meeting and we can go on the record, please. Just let us know when we are.
We're on the record.
A call to order the Green Mountain Care Board's hearing of September 12th. Today we have a number of agenda items, the CVMC fiscal year 24 potential vote. And then we have a number of hospital budgets scheduled for potential votes, including the University of Vermont Medical Center, Northwestern, Gifford, Mount Scottney, Springfield Hospital, Southwestern Vermont Medical Center, and Rutland Regional Medical Center. I'll start with the minutes from September 8th, 2025, and I move for the approval of the minutes.
Second.
All those in favor say aye.
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 Aye. The minutes are approved. I'll ask Dr. Merman to depart so that we can discuss CVMC potential enforcement.
Okay.
I'll turn it to Mr. Sutter.
Thank you, Sheriff Officer. I'm loading slides right now. We have two motions in front of us today. You have a motion for, there's a request for budget adjustment by CVMC for retroactive adjustment. Our staff's recommendation is the board does not approve this adjustment. There's language here, and then there's a motion about potential enforcement to follow.
Are any board questions for Mr. Sutter at this time on this motion? Okay, then I'll make the motion and we can have public comment and board deliberations. I move to deny CVMC's application for retroactive adjustment to its fiscal year 24 budget.
Second.
And any board comment or deliberation? Support the staff's recommendation, made the motion. I think it's appropriate for the reasons stated in the staff presentation, and I'll move for public comment. Actually, I'm sorry, I'll start with the healthcare advocate.
We support the motion, Chair Foster. Thank you.
Thank you. And any public comment? Ms. Noonan.
Yes, thank you, Chair Foster and members of the Green Mountain Care Board for the opportunity to provide comment today. I've been in healthcare for 44 years in Vermont. The space we're in today is the most challenging I've experienced in my many years of practice. CVMC remains committed to working collaboratively with our regulators and others to address affordability and the challenges we're facing. Fiscal year 24 was the first time in 8 years that CVMC had a positive margin. Vermont's aging demographic comes with increasing demands for healthcare services. Not mentioned in the previous deliberations was that 85% of CVMC's NPR overage in 24 was related to providing care to more patients. Approximately 90% of our admissions into CVMC come through our ED. In 24, 9 out of 14 hospitals requested that their patients be transferred to CVMC for ICU and acute care that could not be provided in community access hospitals or in the community. Providing effective and efficient care for those patients was the right thing to do. We also know that providing that care at CVMC opened capacity for UVMMC to provide the tertiary quaternary patient care that only they can provide in Vermont. The Green Mountain Care Board is recommending enforcing 100% of commercial overage and 30% of public payer NPR overage. We don't negotiate rates for Medicare, Medicaid. I would appreciate clarity on how we came to the 30% enforcement for these public payers. A budget is a plan. When more patients come through our doors than we budgeted or anticipated, we have a moral and legal obligation to diagnose and treat them to the best of our ability. That's fundamental to our mission. We will not and cannot turn those seeking care away. Providing care to those who need it when they need it remains our commitment to Vermonters. I hope that you can consider those factors as you continue to deliberate on a potential enforcement action. Thank you for listening.
Thank you very much, Ms. Noonan. Any other public comment? Okay, all in favor of the motions, please say aye.
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 The motion carries. Second, sorry, was there another slide? I move to make a finding that CVMC's performance differed substantially from its fiscal year 24 budget, enforce this deviation by reducing its fiscal year 26 commercial NPR by $11,691,181, and require CVMC to report on the resulting commensurate reduction to its fiscal year 26 reimbursement rate by September 22nd, 2025, which shall be incorporated as a reduction in the board's enforcement order.
I'll second.
Or any board
Um,
discussion?
Yes. So, without reasonable enforcement, the Green Mountain Care Board hospital budget decisions are meaningless. Hospitals must adhere to their approved budgets and manage changes and charges and expenses in order to comply. These decisions are necessary to protect Vermonters from skyrocketing healthcare costs.
Additional board discussion? I made the motion. I respect and appreciate Ms. Noonan's comments. She has a very good point. However, it also has to be judged and balanced against the broader context. Moreover, there's no real evidence that this was a complete surprise that there would be an overage. I believe that CVMC should look to some of its operating and network expenses to reduce the costs, as opposed to increasing charges and then having a budget overage. I think the network expenses that CVMC is forced to pay to the network are unnecessary and should have been reviewed and evaluated for a reduction that would have allowed CVMC to stay within its budget. Moreover, we know that the network has substantial assets that the partner hospitals have to pay for that are not included in CVMC's days cash on hand. We further know that enormous sums of money have been moved from the network to support New York operating expenses and costs. In my view, those monies should have been invested in CVMC. Those monies should have been used to allow CVMC to comply with its budget. This is not a commentary or motion on CVMC. It is more of network operations. And for those reasons, I support the motion. Any public comment? All in favor, say aye.
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 Aye. And the motion carries. We'll have to take a brief recess to get Member Merman back. So we'll come back in 6 minutes at 12:30 and we'll move to UVMMC. Dr. Merman, are you back?
Yep, I'm on.
Great. Okay, we can go back on the record.
And we're on the record.
Great. We will resume the Green Mountain Care Board's hearing. Next, we'll address the UVMMC budget. Mr. Hengsler, did you want to do executive session first before we deliberate?
Chair Foster, I have one quick slide I'd like to present before we do that. There's just a quick correction from the Wednesday presentation. I had mistakenly excluded this $465,000 for the executive raises from the total down here of the budget order rate increase. I just wanted to call that out and show the corrected table on the left. So just increases that amount by $465,000
I see.
above. But that's all for me. Thank you.
And Chair Foster, I think my preference, if we can go through a few recap slides of potential motions that have been or potential conditions that have been presented with regard to UVM. I think we could do a quick overview on those first, and then when we come back from executive session, the board could just move directly into deliberations that way.
That sounds great.
All right, Matt, if you just go to the next slide. So I've gone through these slides a couple of times. I'm not going to read them today, but I just want to give a high-level overview of two options that have been proposed or presented to the board with regard to UVMMC rate and charge growth. So a little background, staff presented on, I believe, the 3rd, I might want to double check my work there, but staff presented, I think it was the 3rd on UVMMC and gave an overview of several reasons that it seemed appropriate for the board to consider a more restrictive particular condition with respect to charge and rate growth. This is something in addition to the standard budget conditions that apply to all hospitals. So since then, there have been two options that have been put forth. I'm just going to explain what they are. This first option is an option in which the board would set a condition for UVMMC, which would require the hospital to reduce all of its rates by the total commercial rate reduction for each payer and for each service. And what that means is that if the board were to take the staff's recommendation of a 4.8% commercial rate reduction, that would mean that every service, every UVMMC service that is reimbursed by a commercial payer would need to be reduced by 4.8%. So it would just be a flat reduction across all services. This option includes a charge condition, which is on the next slide. And that charge condition is the exact same thing. It's a reduction of a 4.8% reduction if the board were to take that recommendation for each charge on the charge master. The only exception is for certain physician services that are reimbursed by Medicare under the lesser of rule. And for those services, UVMMC would have the ability to make whatever adjustments necessary to ensure full reimbursement from Medicare. So pretty straightforward. That's option one. Moving to option two, which was presented at our last meeting. Option two is an alternative to this approach, taking into consideration some objections and clarifications that we received from UVMMC after that first option was presented. This option works a little differently. Here's how this one works. Instead of a, for example, 4.8% reduction for each service for all payers, this would be a order that requires UVMMC's rates for all payers for every service to be, as a starting point, 0% increase, meaning whatever the FY25 contracted amount was, FY26 contracted amount will remain the same. That would be true for inpatient. It'd be true for professional fees, professional services. The exception would be outpatient services. So to get to that total 4.8% reduction across the entire commercial book of business, this condition would require UVMMC to make all reductions in outpatient service rates such that it would comply with the total commercial rate reduction and the equivalent total commercial NPR cap. One of the reasons for bringing forth this option was UVMMC's good faith description in one of its objections that it's been working with payers to try to find places where it can lower rates, and that it believes that there are some outpatient services in which rates should be lower than the 4.8% presented by that first recommendation. So this would be a condition that would prohibit the hospital from increasing rates for any services, but would give the hospital flexibility to work with insurers to figure out which outpatient services should receive reductions to get to the stated goal. And if you move to the last part of this condition, the charge condition operates in the exact same manner in which no charges could be increased and all charge reductions would be on outpatient, and the same lesser of exception for any specific Medicare related issues would apply. So those are the two options that have been presented to the board there. In addition to those two, there were two new motions introduced by the chair last meeting. The first was a loan and transfer restriction, which provides that UVMMC shall not directly or indirectly lend or otherwise transfer funds to UVMHN or funds or services to New York hospitals in the network. And there was a final condition proposed, which was a consistent accounting condition. And that condition is that if the network adopts a method of accounting that consolidates member hospital cash balances into a central account, that UVMMC would need to separately maintain contemporaneous financial records that are consistent with current network and hospital record practices. And my understanding of the goal behind that condition is to ensure that the board continues to have the reporting and information that it needs to sufficiently evaluate the items that are expressed in statute. So this would cover that. So I just wanted to go over those, and then with that, Chair Foster, I do think that I'll turn it back to you for an executive session motion.
Okay. First, before we do that, I wouldn't actually mind hearing from the insurers and UVM as to those two proposals. So one was a minus 4.9% across the board reduction in all charges, and the other was 0, except for a greater reduction in outpatient to net out to a minus 4.9. And if UVM, Blue Cross, or MVP are on, I wouldn't mind hearing their perspectives on those two options. Dr. Leffler?
Chair Foster, thank you for the opportunity to comment. I mean, I'll be honest, the truth is I'd like something in the middle. I like some ability to negotiate what makes sense. Either one of them have challenges built in. They're probably equivalent for us. If we only take all, if we take it all on the outpatient, it will bring the outpatient rates down very significantly, which I know has been an issue. But actually how you put all that together with contracting could lead to other unanticipated changes. You'd have to work through it. So ideally, we'd like to not be boxed into either one of those two, because I think there's a middle ground. I think either one's about the same for us, honestly. Each has pluses and minuses.
Understood.
Thank you.
And Blue Cross or MVP, are you on? Okay. All right. Well, thank you for your comment, Dr. Leffler. So the board will move to executive session. We received some legal objections yesterday from the health network. And so I'd like to do that. So I move to make a finding that premature general public knowledge of confidential attorney-client communications would clearly place the board at a substantial disadvantage.
I'll second.
All in favor, say aye.
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 Aye. Motion carries. I move that we enter into executive session pursuant to 1 VSA 313A1F for the purpose of seeking counsel from the Green Mountain Care Board's counsel. Attendance at the executive session will include board members, counsel, and necessary Green Mountain Care Board staff.
Second.
All in favor, say aye.
Aye.
Aye. And the motion carries. Mr. Hengsler, about how long do you think you need to walk us through the legal issues?
I believe that at our last session, we said 45 minutes and it was an hour. I think that this will take 30 minutes, so let's say 45, and I think that'll be right.
Let's say 30. We'll see if we can extend it. So we'll come back at 1:10. 1:10, and we'll notice if we need to take additional time. So we'll take a brief recess and we'll plan to be back at 1:10. Thank you.
I'm just seeing, it says people, 112.
No, that can't be possible. But
Are the board members all back?
Is Tom on here?
Yes.
Jess, are you here?
I'm here. Yep.
Great. Okay, and can we go back on the record, please?
We're on the record.
Thank you. We'll resume the Green Mountain Care Board's hearing of September 12th. We'll move to deliberations on the University of Vermont Medical Center's budget. Mr. Sutter or Mr. Henksler, is there any additional information from the staff?
No, Chair Foster, we have motion language available here. Also.
Okay. I'll start with the motion language and then we can have deliberations. I have some information I'd like to share to explain my rationale, but we'll see if there's a second on the motion first and then we can deliberate. So I move to approve UVMMC's budget with the following modifications. Total NPR approved at not more than 0.6% over fiscal year 25 approved budget with a total NPR of not more than $1,914,078,939. Commercial NPR approved at not more than $1,084,914,992. Commercial reimbursements rates reduced by at least 4.8% over current approved levels, subject to the following hospital-specific conditions discussed today. And we can show the prior slides. So I go to the next one. Go to the one about the accounting. I would include this condition, which is if UVMHN adopts a method of accounting that consolidates member hospital cash balances into a central account, UVMMC shall separately maintain contemporaneous financial records that are consistent with current network and hospital record practices. And if you go back to the main slide with the main conditions, the first one you showed, and subject to all their standard budget conditions as approved by this board.
I'll second.
And let me just sort of summarize, since there's been a number of proposals that were presented to the board. The motion I made was for the 4.8% reduction across all service lines with the accounting requirement condition, without the prohibition on the transfer of funds, and without the reduction being modified lower for outpatient services. I have one comment on the motion. UVM objected to us prohibiting transfers of Vermont dollars to New York. I dropped that. There is an alternative to dropping that, which is UVMMC has budgeted $16 million being taken from the University of Vermont Medical Center to cover New York financial shortfalls. What is not entirely clear to me is whether or not that $16 million UVMMC is budgeting to remove from the University of Vermont Medical Center for the benefit of New York is included in the $72 million margin they budgeted, or if it is in addition. If it's in addition, I do think we should deliberate and discuss whether or not the reduction should be further to account for the fact that UVM is planning to remove $16 million from our academic medical center, given that they have made legal objections that we're not allowed to prohibit them from transferring Vermonters' money. So I guess I'll stop there. I would ask UVM to answer that question, whether or not the $16 million, $15 million in loans and $1 million in capital investments is in addition to the $72 million margin or out of that money. Mr. Vincent?
Good afternoon, Chair Foster and the board. So in terms of the budget, the operating budget, there's no change there. So that 16 million is a balance sheet item, and the balance sheet budgets that we submitted did include an assumption for where cash would be for this coming year.
Okay, so so you're planning to have $72 million in margin out of the budget. And what you're saying is that 16 million would be reduced from the balance sheet at the end of the year?
No, so it's in those numbers. So the operating budget is that 16 million is not in addition to the operating budget that you're approving today.
Got it. Thank you. Is there any other public comment on the motion?
I would like to second but amend your motion.
One second. Why don't we deliberate first, and then we can see if we should amend the motion. I think that would be the better process. Although before we do, you're welcome to just say it, and then we can formally see if we need to take a friendly amendment.
Sure. So I largely support your motion, Chair Foster. I would like option 2 under the rate and charge conditions that puts more emphasis on outpatient than on inpatient and professional.
Thank you. Other board members, particularly on the point that Member Teachout made?
This is Tom. I support the greater focus on outpatient.
I do have comments I want to make to explain why I made this motion. And I know other board members probably have additional thoughts. So if you wouldn't mind, I'll explain my rationale for why I made the motion, and then other board members can discuss their thoughts as well. Ms. Parker, do you have the slides I prepared?
Sorry, can you say that again?
Do you have the slides I prepared? I sent you some slides.
Oh, yes.
IST is Chris speaking. How may I help you?
Abby, do you have them available?
I'm working
Or maybe Ms. Lajeunesse, do you have them handy?
those up right now. Yeah.
Sorry, Abby, I'm getting like a little bit of random noise. Do you have my slides available, and can you pull them up? Just going to take a moment to go off screen and call and check in. Thanks. Seems we're having a technical difficulty, so why don't we just take just a 3-minute break, and we'll see if we can get the slides to be displayed. So we'll come back at 1:27. Thanks.
And we're off the record.
Okay, thank you, Susan. It looks like I can see them. Perfect. Okay. We can go back on the record.
We're on the record.
All right, I apologize for the technical glitch. So you can go to the next slide, Susan. So I wanted to express some of my views because I think it's important to explaining the motion as it's a significant change in the proposed UVM budget. Staff recommends the board approve a budget with zero margin for UVMMC. And I agree that in the context of our healthcare affordability crisis, SVMC's request to increase commercial revenue to cover its losses from suffering 340B, Copley closing birthing, insurer insolvency, sustainability concerns at rural hospitals, mental health, long-term care, and primary care providers. It would be inconsistent with our statutory charge to provide more reserves to the University of Vermont Health Network, given its use of Vermont money to cover its inability to sustainably operate New York hospitals that it owns. UVMMC's reserves are, or should be, considered significantly more robust than the University of Vermont Health Network portrays them for three reasons. First, the University of Vermont Health Network deprives the University of Vermont Medical Center of over $100 million by using Vermont reserves to pay New York hospital expenses. In fact, the University of Vermont Health Network took over $10 million from Vermont to cover New York expenses in the same year that the health network cut essential services in Vermont. Second, UVM Health Network forces Vermonters to subsidize insufficient payments to its New York hospitals through higher margins in Vermont. Third, the University of Vermont Health Network has taken $50 million from the University of Vermont Medical Center and taken on hundreds of millions of dollars in debt that Vermont overwhelmingly pays for. But the University of Vermont Health Network does not count those assets in calculating UVMMC reserves. The University of Vermont Health Network does not provide health care. It's essentially an expensive and ineffective layer of overpriced and unnecessary corporate bureaucracy that has proven itself both physically and spiritually distant and unconnected from the mission of our flagship academic medical center and the needs of Vermonters. Under current UVM-HN management, we have seen unrelenting expense growth far exceeding inflationary metrics, dramatically declining quality across the University of Vermont Health Network hospitals, large and unnecessary health network executive compensation and bonuses, and a growing gap in compensation between the lowest paid patient-facing employees and network executives. We have seen excessive charges to Vermonters for life-saving medications, MRIs, and CTs, and a backlog of over 3,000 patients waiting to get a colonoscopy. We have seen removal of $100 million of critical resources from our flagship hospital to pay for New York expenses, and an expensive communications and lobbying arm, including out-of-state staff and consultants, whose work has led to a deterioration in UVM's reputation and Vermonters' trust in UVM. Vermont hospitals pay around 80% of the unnecessary expenses associated with tens of millions of dollars in network executive compensation, external relations, network finances, etc., that have not been established as necessary or appropriate expenditures, particularly in light of the essential services we may be losing here, such as primary care, FQHCs, birthing, etc., which I think are a far greater priority than UVM's lobbying, branding, and excessive administrative layer, and transfer of our funds out of state. Next slide. A major issue in the UVM Health Network budget is the removal of dollars from UVMMC to support New York hospitals. This has been an important issue for the Green Mountain Care Board, yet we've seen inconsistent testimony and evidence describing what's going on. In House Healthcare Committee this year in February, Dr. Epen, the CEO of UVM Health Network, testified that the New York financials has no impact on the margin, the cost structure, or the commercial rates that are charged. He further testified that Vermont dollars stay in Vermont and that they're careful to not cross-subsidize. Similarly, the CFO, Mr. Vincent, this year testified that these are not loans and that they shouldn't be considered loans. Next slide. However, the record before us plainly shows that the University of Vermont Health Network is subsidizing New York operations in three ways that can only be done directly or indirectly through charging higher commercial rates to Vermonters. and I will walk through each of those. First, in contrary to recent leadership testimony this year, UVM itself has described the University of Vermont money the network uses to pay for New York hospital expenses as a loan. In fact, UVM described the money given to New York as an outstanding loan and loans for which repayment would be reflected and tracked. Prior to UVM-HN leadership, current leadership, New York actually did repay a small portion of the loans. It repaid $2.2 million. If it's not a loan, it wouldn't be called a loan, and there wouldn't be a repayment, and it wouldn't be called a loan. Similarly, in prior years, Mr. Vincent described the money as, quote, it's money that's owed to the University of Vermont Medical Center from the New York hospitals. When you owe money, we call that a loan, as UVM itself did prior to the GMCB focusing on this issue. Next slide. In response to the Care Board's budget decisions last year, the Green Mountain Care Board cited UVM's excessive commercial prices, the New York loans, and poor network operations and management when we denied the large increase of commercial dollars the health network requested. What ensued is a stain in our healthcare history. The University of Vermont Health Network, not the medical center, the health network, cut sensitive services. It laid off Vermonters. It blamed the regulator for its decisions. In reality, UVM did not need more money to provide the dialysis, mental health, and primary care Vermonters so desperately needed. I saw this in real time, this article with a picture of the woman with the question, where is the money? And I asked myself the exact same question, where is the money? And I'd like to address that. It is in New York, and it is there because the University of Vermont Health Network has failed to obtain sufficient reimbursements in New York to run those hospitals. And so it's taken Vermont dollars and it's put them in New York. Next slide. So you can see here in 2025, the fiscal year in which UVM the health network cut essential services in Vermont, it took over $10 million of UVMMC's money and spent it to cover expenses for New York hospitals. At the same time, UVM Health Management and External Relations was telling the Care Board, legislators, the media, and the public that it couldn't provide life-saving dialysis services because it didn't have the money. While it did that, it was shifting money to pay for New York expenses, as demonstrated in this document. As you look here in 2025 projected, it shows $19.6 million being projected as an outstanding loan to the New York hospitals. We received an update, and it sounds like this number is actually now projected to be more around $10 million, not 19. Nonetheless, at least $10 million was spent in New York expenses as opposed to covering our sensitive services here. Likewise, in this year's budget, UVM Health Network is planning to take $16 million from the University of Vermont Medical Center to pay for New York expenses. UVM-HN claims that the University of Vermont Medical Center needs margin to provide life-saving care and to invest in our academic medical center. However, contemporaneously, it is removing $16 million from UVMMC reserves to cover for its inadequate reimbursements in New York. It is not Vermonters' responsibility to cover for poor negotiations with New York insurers and insufficient New York Medicaid. Let me be clear. I fully support those New York hospitals and those patients' rights and needs to have a well-funded, well-operated hospital. Where I differ is that it is not Vermont commercial ratepayers' obligation and responsibility to cover for inadequate management of those hospitals and inadequate negotiation for price with the commercial payers. Importantly, the drain of Vermont resources to New York has vastly accelerated under Dr. Epen and this current health network management team. Dr. Epen arrived in fall of 2022, and in the 3 years prior to his tenure, UVMMC loaned New York a net of $8 million, or about $2.6 million per year. As shown in this document in the top, New York even repaid University of Vermont Medical Center $2.2 million in 2021. Under Dr. Epen's leadership, the dollars out of UVMMC to pay for New York expenses has increased dramatically, from $8 million in a 3-year period to over $67 million in the last 3 years. That's an over 700% increase in the amount of money that's being taken from our academic medical center to pay for New York expenses. Next slide. So where is the money? This slide shows you. It's $13 million at Alice Hyde to cover payroll and its share of the University of Vermont Health Network's administrative bureaucracy. It's $88 million at Plattsburgh to pay for doctors in New York and for pharmaceuticals for New York patients. And it's $1.4 million at Elizabethtown to pay for doctor salaries and the University of Vermont Health Network's own administrative expenses. UVM HN argues that this is okay because they get revenue from New York patients coming to Vermont. This argument is baseless and misleading, and the state can go nowhere in healthcare until we start being entirely candid and honest with each other about what's going on. New York patients always came to UVM. In fact, the number of patients coming to UVM from New York has been generally flat, and patients were coming to Vermont long before the health network started loaning New York money or increasing the volume of those dollars going to pay for New York expenses. There is no reason New York insurance companies, which are bigger and have far more resources than Vermont's insurance companies, and New York Medicaid shouldn't pay their fair share of costs for those hospitals, and it is illogical and inconsistent with my statutory obligations to allow Vermonters to pay New York expenses to make up for this shortfall. UVM needs to manage those hospitals in a sustainable way and not come to Vermont and take our limited scarce dollars to cover for those shortfalls. There is simply no justification that Vermonters should have to pay more to UVMMC this year while the health network fails to ensure sufficient payment from New York insurance companies to cover those operations. Next slide. For years, UVM has indicated it was important to keep New York and Vermont funds separate. The UVM-HN CEO this year testified to our legislature that the health network is careful to keep the funds separate and that they track the money separately. On Wednesday, I introduced a condition that I thought was consistent with Dr. Eapen's testimony. I proposed simply that UVM be required to account for financial transfers to New York and the health network in the very same way it currently does and always has. I think that is appropriate. Yet last night, UVM's legal department sent a letter to the Care Board objecting to the condition. While Dr. Eapen says that UVM is careful to keep the funds separate, the legal department now says the Care Board is prohibited from requiring UVM to have the exact same regulatory reporting process it's used previously. It goes without saying that legally objecting to something so basic as requiring accounting of our academic medical center's money is deeply troubling. Next slide. I will note that the language the health network uses to describe giving Vermont money to New York has evolved. It was a loan, and it was money owed to us by New York. More recently, that has morphed into financial transfers, internal transfers, and a funds flow. We can keep trying out new words, but it does not change anything. The health network is charging more in Vermont than taking the reserves it generates and using it to pay for New York expenses. Moreover, this letter says that the Care Board is prohibited from stopping those transfers. In fact, it calls it, let me see the language here. Calls it a highly consequential condition to prohibit the medical center from using our money to pay for New York expenses. But if it's not happening, it cannot be a consequential condition. Moreover, this letter says that the organizations rely materially on the ability to support each other financially. I find this inconsistent with the testimony in House Healthcare and previously to the Care Board, which made it sound as if money was not being used in that way. Go to the next slide. So the first way in which money is being used to subsidize inadequate rates in New York is UVM using higher margin in Vermont to cover up for lower margin in New York. Go to the next slide. The University of Vermont Health Network has a network-wide margin, and what that means is if the health network fails to obtain sufficient payment in New York, it has to make up for that by charging more in Vermont. This is in addition to the over $125 million in direct subsidization through loans or funds transfers. As you can see here, UVM New York has had a loss of nearly $100 million. Those losses have deepened significantly in fiscal years 22 through 24, despite UVMMC paying many of New York's expenses. So how does the health network management make up for this? By taking more of Vermont's healthcare dollars. While New York has lost nearly $100 million, as shown here, Vermont has made nearly $450 million in that same time. That huge margin in Vermont is predominantly coming out of higher commercial dollars. UVM loses significant money on Medicare and Medicaid, and its operating expense growth far surpasses any inflationary metric. And what that means is that $445 million is largely due to Vermont commercial ratepayers. So it is subsidizing. If you are too low here and you have a network-wide margin and you make it up here, it is subsidizing. Go to the next slide. Back in 2021, UVM acknowledged this. In this budget narrative to the Care Board, they wrote that they have a system-wide margin that can only be achieved if UVMMC attains a higher margin to balance the remainder of its health system. That is a subsidy. You charge more here to increase your margin in Vermont, which you have to do because you can't run your hospitals in New York sufficiently, and you fail to require New York insurers to pay the cost of providing that important care to those people. Next slide. The shortfalls in New York are overwhelming. CVPH in Plattsburgh has 1.6 days cash on hand. That's just over $2 million, or stated another way, only slightly more than the health network CEO's salary. The New York Reserve shortfall, which Vermonters make up for through higher margin at UVMMC, is enormous. By my estimates, it would take nearly $150 million for the New York hospitals to contribute 130 days cash on hand, which is about the network reserve level. Next slide. That UVM has failed to obtain appropriate cost coverage in New York is not debatable, nor is the fact that UVMHN is making up for that failing on the backs of Vermonters. The UVM Health Network CFO confirmed, as he must, that the dollars UVM Health Management is getting to pay for New York hospitals is not sufficient. Next slide. Lastly, UVM has failed to show that we should give it $72 million in margin because UVMMC actually has more dollars than portrayed to the Green Mountain Care Board because the health network has taken $50 million in assets out of the medical center and removed it from UVMMC reserves. What's more, the health network has taken $250 million in debt that the University of Vermont Medical Center has to pay for out of operating expenses in its reserves, but which the University of Vermont Health Network does not count towards the medical center's reserves. Accordingly, given this huge amount of money, there's no showing that UVMMC needs more reserves. They're there, they're at the network. Next slide. As shown here, the University of Vermont Health Network took $50 million from the University of Vermont Medical Center in 2018. This money was removed from the medical center's reserves. UVM Health Network then took on $250 million in debt between April of 2020 and December of 2022. The proceeds of this debt was put on the health network's balance sheet. And the health network's management and board has control and discretion over those funds, not the medical center. Next slide. The problem with that is that the University of Vermont Medical Center and Vermont hospitals pay the lion's share of the expense associated with those assets. The interest on those loans is over $31 million, and the principal payments are over $26 million, as shown here. The interest on the loans is paid out of UVMMC as an operating expense, which Vermonters overwhelmingly cover. Vermont hospitals pay for the principal out of their reserves. So you take the money, you put it at the health network, then you have an operating expense to pay the interest on the money you don't control, and then you take out of the reserves to pay for the principal for the money that you don't control, and you are not credited in your reserves. This is a corporate shell game, and it has the effect of increasing Vermont hospital operating expenses, which are used to justify higher rates. It also reduces Vermont hospital reserves by removing reserves to pay for the principal. UVM Health Network then relies on those lower reserves to say they need more margin so they have healthy reserve levels. In sum, Vermont hospitals overwhelmingly foot the bill for this debt, but have no control over it, and the proceeds are not counted towards our reserves. Next slide. This is from the medical center's position on the Care Board's recommendations, and it correctly cites the need for margin this year so that it has adequate reserves. And it notes that those reserves are needed, quote, to ensure investment into facilities and continued ability to be deemed a financially sound institution for which Vermonters can count on to deliver needed care not available anywhere else in Vermont. Margin allows UVMMC to purchase new equipment and replace aging equipment. Margin allows UVMMC to continue to provide life-saving and lower volume specialized treatment for the communities it serves. I could not agree more. The problem is that the hospital doesn't have control over its own margin or reserves, and the corporate parent has proven itself an irresponsible steward of Vermonters' dollars. We can't give UVMMC the margin. Its network parent is planning to use the reserves to cover for its inadequate rates in New York. At a time when Copley is losing birthing, many other hospitals are going to cut services, and we can't afford health care here. So how could we responsibly give margin that we know will not stay here and be invested as portrayed here? This also states that UVMMC is critically important to the care delivery system. Avoiding zero to negative margins should be a statewide focus to ensure the investments can be made in facilities and services such as cancer and other specialties. Again, agreed. This is why I am incredulous that the $127 million of margin that we have given to UVMMC to invest in that critical hospital, and we have allowed UVM to charge Vermonters, has not been used solely for those purposes, but rather to cover for inadequate rates at hospitals that Vermonters do not go to, by and large. Go to the next slide. So I want to wrap up, but in conclusion, the University of Vermont Health Network took over $100 million of UVMMC's reserves, and the GMCB cannot provide the University of Vermont Medical Center margin given the financial crisis here and the health network's history of using UVMMC margin to pay for New York expenses and to cover for the health network's deficient management of its New York hospitals. UVMMC is paying tens of millions of dollars of health network expenditures that have not been shown as necessary given our affordability crisis, including an additional and unnecessary layer of corporate bureaucracy and health network executive administrators that actually remove critical assets and resources from Vermont and our flagship academic medical institution. Large and expensive public relations and lobbying apparatus, including numerous outside and out-of-state marketing and lobbying resources, and over-indexed IT, population health services, HR, and other shared services. The health network is budgeting to use $16 million of medical center assets to cover New York expenses in 2026. The health network has used higher Vermont commercial prices and margin to subsidize its failure to sustainably operate its New York hospitals. The health network has artificially lowered the University of Vermont Medical Center reserves by removing reserves from the medical center and requiring the medical center to pay for debt held at the health network that does not count towards the medical center's reserves. Next slide. The University of Vermont Medical Center, in my opinion, is an absolutely critical resource for Vermont and should not have its resources depleted and its services cut while the health network uses Vermont resources to cover for the poor operations in New York. Given the financial crisis, UVMMC should seek to be fully funded as requested in its budget, and it should obtain that $72 million in fiscal year 26 margin. It should do so by being paid back for its loans to New York. It should do so by reducing its costs spent covering unnecessary and duplicative health network administrative expenditures and PR, lobbying, and marketing costs, and being repaid its reserves that were removed by the health network and being credited for the debt that the medical center itself pays for. The University of Vermont's Medical Center's problem is not with the Care Board or Vermonters' inability to give it money. It's with its own corporate parent that has drained its assets and forced it to pay for an unnecessary layer of corporate bureaucracy. The health network has proven to be an irresponsible steward of Vermont's limited healthcare dollars. UVM Health Network's management and external relations have provided, at best, inconsistent and misleading state testimony and public statements. And until such time as the medical center is responsible for its own management and money, or the health network changes in dramatic ways and establishes itself as a credible and trustworthy partner and responsible steward of our scarce healthcare dollars, I cannot support the health network's demands for more of Vermont's healthcare dollars. The University of Vermont Medical Center Board has a choice and is at an important inflection point. Your jobs are hard, many of you have full-time employment and other responsibilities, and you're volunteers who are not compensated. However, you are the ones ultimately responsible for the most important medical facility in this state, the University of Vermont Medical Center. You signed up for a critically important job, one with fiduciary and moral obligations to the medical center and to Vermonters. If and when the health network or the medical center are ready to change, the state will be there, we will advocate for federal funding for you, and we will look differently at your rate and margin requests, and we will support you. But that change needs to happen and needs to happen decisively. I have no other comments at this time.
Chair Foster, let me bring up the slide deck from before.
Can you move to the motion language, Matt? Any other board member discussion?
I have comments, but I'm not sure if others wanted to go first.
I can jump in. Unless member T-Chat, did you want to go?
Go ahead, I'll go after you.
Okay. Well, I don't have any slides prepared, and I had prepared a lot of comments, but I think a lot of them are less thorough versions of what Chair Foster just discussed. So I think I'm going to focus on just one area for today. That's on this relationship that's been discussed not so much in this budget process, but much more in public communications, which is the relationship between revenue and patient care. And as a clinician, I think this is something that this equating revenue with patient care is quite a challenging and fairly demoralizing relationship. So I think of revenue as money, not patient care, it's money. And it's money that comes into an organization. And for UVM Medical Center, it's the money that comes into the medical center. Sometimes it's confused with gross revenue, which is based on all the charges. This has been a little bit challenging. There's been media reports of UVM having 2/3 of its revenue from public payers. That's gross revenue. It's actually closer to about 41% of its revenue comes from public payers, just over a third. Patient care is quite different than money. When I try to think about what patient care is, I think about the work that I do in the emergency department. I think about my nurse colleague who's sitting next to a loved one of a patient as they're struggling with a critical illness. I think about the complexity that they're doing when they're titrating drips. I think about the blood bank tech that runs blood to the emergency department. I think about the registration clerk, when my neighbor goes in for their radiation oncology and they're having a stressful time, that clerk meets them and connects with them. I think about the CT tech that brings the patient down the hallway and says, "How you doing today?" And they engage in a conversation to comfort them. And the mental health tech who sits with that patient who's in the deepest, darkest hole in their life, and they help them dig out. And I think about a surgeon who brings a patient to the OR to take out their gallbladder, which is a routine surgery, but yet at the same time, the patient has trusted them with reaching into their body, and the slightest mistake could completely change that patient's life. That's patient care. Not all of that leads to revenue, but you do patient care, you document. Documentation gets coded. Codes get made into charges. Charges get submitted. Public payers pay on, basically, they determine the rates, and commercial payers negotiate prices. They pay that, and that's revenue. UVM has previously put up a slide in prior years of revenue equals price times utilization. I think this is a much more realistic slide, but just the complexity of what utilization is. Utilization is not just patient care. Utilization is coding and distribution of charges, and like how do you align the codes with charges. So revenue is money, and patient care is patient care. And sometimes patient care generates revenue, and sometimes revenue is generated from goods and not so much services. But it's been really harmful. And Owen mentioned the spiritual disconnection of the network and the Vermont hospitals. And I think this is an example of that disconnection to equate the work that your workforce does as money for the network. I also think there's been a distortion of what an NPR cap, a net patient revenue cap, means. Because there's discussion, occasionally we see public comment about limiting access to care due to being concerns of coming up with a cap. That ignores the price component, that a hospital can lower their prices to deliver the care. And I was very, very happy to see that UVM in a response said that they do not avoid providing care to avoid going over the revenue cap, because there's an easy adjustment to that, which is reducing prices. I guess that's all I wanted to say. Thank you.
Great. I'll jump in with my comments. The status quo isn't working for Vermont. This is an extremely disappointing that UVMMC submitted an FY26 budget with increases in revenue, increases in expenses, and increases in FTEs at a time when our state healthcare system is crumbling. There are many disturbing aspects of the proposed budget that Chair Faster went into great detail about. For me, maintaining extraordinary levels of reserves, subsidizing New York State hospitals with Vermonters' healthcare money, paying substantial salary increases to executives, a confrontational and litigious approach to regulation, and accounting for almost all of the operating margin across the 14 hospitals in our state system, and spending millions on misleading communications. These aren't the actions of an entity that is serious about solving our state's healthcare issues. And yet, the hospital is critical to the health of Vermonters and the functioning of our system of care. My decision will reflect my best effort to move forward in this difficult and dysfunctional environment. And that's all I have.
I can hop in here. I also don't have slides. I do have a lot of thoughts from this year's budget process. I'll try and focus on a couple of key takeaways from me. Some of them are similar themes that you heard already. Others have heard already, others have said already. The first, I think, theme or key point for me was around governance and decision-making. It's really become abundantly clear to me over the past year that critical decision-making, both financial and clinical, actually no longer rests with the partner hospitals and their boards. Most of the locus of control and therefore accountability for UVMMC performance lies with the network leadership rather than with the hospital management team. Whoever controls the resources controls the outcomes, and UVM Health Network clearly controls the resources available to the medical center. According to UVM's response to one of the interrogatories, and I quote, they said, the UVMMC Board of Trustees has delegated formal approval of the UVMMC hospital budget to the UVM Health Network Board of Trustees. I don't know when this delegation occurred. I don't understand, frankly, why. But that delegation of fiduciary responsibility does not appear to be in the best interest of Vermonters or the academic medical center. I hope that the UVM Medical Center Board can reclaim their authority to approve their own hospital's budget. The deference to the network was clear in the UVMMC hearing. UVMMC leadership appears to have little say over its required contribution to network shared services, the $330 million that's in the fiscal year 26 budget. And they have even less say on how or even in which state that money is spent. There was no evidence in the record that UVMMC's $333 million shared service investment generates equivalent or greater value for the medical center and its patients. This is concerning to me. It makes it hard for us as board members to evaluate whether these contributions to the network are consistent with the efficient and economic operation of the hospital. We know the cost of the shared service investment, but we have no evidence on the net benefit to UVMMC. And more troubling, neither nor do medical center leaders or their board. There's a lot of blind faith that the ROI on that $330 million contribution to network shared services is positive. I'm not convinced. When we look at the ways in which those shared service dollars are spent at the network, it raises more questions for me than answers. I'll give a couple of examples. I think as I mentioned in the hearing itself, back in fiscal year 22, the network had 139 people working in quality population health. It's about $21 million. Back then, UVMMC was a 5-star CMS rated hospital. So was CVMC. I think Porter was a 4-star rated hospital. If we fast forward to fiscal year 26, the network has now consolidated quality, high value care, population health of the network. There's 237 people with a $41 million budget. And as consolidation of the network occurred between 2022 and 2025, UVMMC went from a 5-star hospital to a 3-star hospital. CVMC went from 5 stars to 2 stars, and Porter has gone from 4 stars to 3 stars. The network literally has hundreds of people dedicated to quality and population health outcomes, yet both in New York and in Vermont, there are no 4 or 5-star hospitals anymore. The burden is on the hospital to show that this consolidation and shared services contribution is money well spent, which frankly they could not do. There was not evidence of that in the record. The fiscal year 26 network shared service budget has 41 people in external relations, and that doesn't count the additional contracts the network has with outside lobbying firms or the 26 people in development and fundraising. I'll note that we asked UVM Health Network for the communications and lobbying contracts to be broken out separately in their purchase services, but they didn't provide that to us. Again, the burden is on the hospital to justify expenses, these types of expenses, and there's no evidence in the record that this category of shared expense improves quality, access, or affordability for patients seeking care at the medical center. And I'll echo my colleagues' comments about the misleading communications coming out of the network. It's troubling. We shouldn't be spending money on that. The network was supposed to generate efficiencies and cost savings for member hospitals. I did not see and could not find any compelling evidence of efficiency gains for the medical center. Both last year and this year, UVMMC shared historical data on its expense per adjusted discharge relative to other teaching hospitals. According to that data that was submitted over both years, last year and this year, if we look at back in 2021, UVMMC's expense per adjusted discharge was well below the 25th percentile among teaching hospitals, among peer institutions. Now it is at about the 50th percentile. That means expenses per adjusted discharge at UVMMC are growing faster than its teaching hospital peers. So where are these promised savings, these promised network efficiencies? Consolidation of shared services at the network should be lowering expense per adjusted discharge relative to peers, not increasing it. One of the expense drivers at UVMMC has been its travelers. And one of the assumptions in the medical center's fiscal year 26 budget is that the medical center will meet the Green Mountain Care Board's 3% expense benchmark by reducing travelers by 44%, $18 million in anticipated savings. I applaud the effort. I hope they can achieve this goal, as it should improve quality, it should improve continuity of care. But I do question the reasonableness of this assumption in the budget. The 2025 Employee Engagement Survey results indicate that staff pride in the organization and job satisfaction at the medical center are in the 20th to 25th percentile nationally. With job satisfaction and pride that low, I worry about both recruitment and retention of staff who have many outside options. And frankly, if they could eliminate travelers that fast without compromising access to care, why haven't they done so already? The UVMMC leadership and board must have a contingency plan to cut expenses should they not be able to meet these traveler reduction goals, a plan that does not involve cutting essential services as the network leadership did last fall. UVMMC leadership needs to regain some control over its budget and look to the $333 million network shared service contribution as a place to start. Another place to look is expense savings related to the loans and transfers to New York, as Chair Foster outlined. As others have said, it's really troubling to learn that over $100 million has been taken out of UVMMC's margin and or their reserves to fund New York operations, almost $70 million since 2023, another $16 million on the books for fiscal year 26. And again, as Chair Foster said, whether we call it a loan, an obligated group funds transfer, or the New York hospital bailout that it seems to be, that $100 million plus funds flow has been largely paid for by commercial ratepayers at the medical center, a population that is paying already some of the highest hospital prices in the country and faces the highest health insurance premiums in the country. Absolutely agree with Chair Foster. New York patients deserve access to high quality care, but Vermonters right now, we cannot afford to fund it. Not when our premiums are skyrocketing and our access to quality care is deteriorating. So I ask a thought question here. Imagine if that $100 million had been instead dedicated to increasing access to specialty care at the medical center. Despite lots of promises by the health network leadership and their communications team about doubling down on access and improving wait times, patients still face exceedingly long waits for much needed care at the medical center. We just received another public comment about wait times at the medical center this week. And despite long waits, UVMMC provider productivity is still low, often below the 50th percentile and even below the 25th percentile nationally. But again, the locus of control over the medical practices lies with the network. The medical group does not actually report, the medical group president or executive director does not report to the UVM Medical Center president. That executive director reports up to the UVM Health Network. So hiring, scheduling, productivity expectations, deciding where medical center providers work, in other words, how many days they're working at the medical center versus how many days they're working in Plattsburgh. These are, again, network allocation decisions outside of the medical center leadership's control, seemingly. What if that subsidy to New York that the network sent over there had instead been invested in ensuring highest quality care at the medical center, or invested in wages and workplace culture to attract the most talented medical providers, and to ensure a permanent, proud, and satisfied workforce at Vermont's tertiary care center? Perhaps UVMMC would still be a 5-star hospital. So I agree, operating margins are critically important, and there is margin to be had here for the medical center, but it needs to come from reducing the $330 million network shared service contribution and or by repayment of the millions of dollars in subsidies flowing from the medical center to New York. Forcing repayment of those past transfers could add significantly more to UVMMC's bottom line. So circling back to my original point, I believe governance and locus of control needs to change. The UVMMC leadership team may be doing the absolute best with the resources that their parent corporation allows them to retain. But given the profound access challenges, quality deterioration, and excessive cost growth, that resource allocation is not working for Vermonters. Something needs to change, and I hope the board's comments today and the budget modification that's before us today and decided upon today will force that change. Those are my comments. Back to you, Chair Foster.
Thank you very much, Member Holmes. Member Walsh, did you have any perspectives, thoughts on the motion before us?
Thank you. Very brief comments. I agree wholeheartedly with my colleagues. The one thing that I would add is that the amount of money that we're talking about with these comments is enough that we would not have had to increase commercial rates had this money stayed locally. Vermonters, regardless of whether they're using Health Network or UVMMC services, are paying these dollars. It's affecting the state. The extraction that Chair Foster has described coming out of UMMC is also happening at Porter, also happening at CVMC, and from Vermonters' wallets.
Thank you, Member Walsh. I'm going to withdraw the motion in light of Member Teachout's proposal. I'm going to take public comment, and then we can make a new motion pursuant to Member Teachout's request. Ms. Peakley?
Chair Foster and Board, thank you for allowing me to speak. I wanted to make a statement that UVMMC is committed to working with the Green Mountain Care Board to deliver care with a focus on affordability and access. I respectfully request that the Green Mountain Care Board allow UVMMC to have a margin to invest in UVMMC and in patient care through non-commercial ratepayer sources. Thank you for this consideration. And thank you for your time today.
Thank you. Would you agree as the CFO of the medical center to not allow a transfer to the Health Network or New York?
I could not comment into whether or not that is within my scope of control or the needs that we would have to address as a network or other hospitals within Vermont. So at this point in time, I would not be able to address that.
Understood. Thank you. Any other public comment at this time? Dr. Leffler.
Chair Foster and Green Mountain Care Board members, thank you for the opportunity to comment. I appreciate the presentation and all the work that went into it and all your comments. And I understand there are things that need to be better about the network. I do understand that. I do want to make a very brief comment. There's much good in the network as well. There's much good that serves patients across our whole region. There's good for our clinicians, our learners, and I agree with many comments about how we have to be better and work better with you. But I do caution not to throw everything about the network away. Many good things have happened. Vermonters and upstate New Yorkers now can go across the region, use one seamless electronic medical record to deliver care, one system for x-rays, no matter where they show up. We have providers that do move and provide high quality care in both states. The network does allow us to have increased specialty services in different regions and actually does help, believe it or not, access to the medical center because patients from New York, if they were weaker, would end up in Burlington. So I greatly appreciate the presentation. I understand the network needs to be better. I do caution that throwing away everything about the network would not be good for anyone. Thank you.
Thank you, Dr. Leffler. And I think you're entirely correct. There is a lot of good and a lot of opportunity with the network, no question. And the things that you cited, if there are efficiencies, that is beneficial. Sharing the EMR is beneficial. One system for x-rays is beneficial. All of that can be done with the medical center running the operations of the shared services of the network. And we could avoid some of the downside of seeing some of the funds flow out of Vermont hospitals. CVMC is crumbling and falling apart and has a really old age of plant. And yet the health network has taken the money from your hospital and invested it in New York costs, when that would be more appropriately used for Vermonters' benefit at the Central Vermont Medical Center. This is really an issue, not with the potential for shared services, which are seriously a very good potential, but more of this money in Vermont is being used to subsidize inadequate rate and inadequate operational management of the New York hospitals. That's really what this is about. My comments were not directed at that there isn't an opportunity for positive things from shared services. Alex Claire?
Thank you. I'm not a lawyer, but how is that not fraud? That's insane. How are these people still employed? They're taking our money and investing it into the New York hospitals. $100 million is a lot of money, and we've been jacking up premium increases for a number of years to cover their losses. That's not cool. How do we stop UVM from sending money to the network to send to the New York hospitals? Can UVM lock them out of the bank accounts, or does the network control the bank accounts? This is absurd. I cannot believe that it's taken 3 years to figure out what the problem is. I can't wait to hear what the UVM board person has to say, because I want to hear what he has to say. Thank you.
Thank you for your public comment, Mr. Leclerc. Mr. Davis?
Can you hear me, Mr. Chairman?
Yes, sir.
I'm puzzled, given all your slides and the unanimous feeling of your board. Why did you did I mishear you saying that you took out the original the part of the staff recommendation that you forbid UVMMC from transferring any money to New York? Did I mishear that?
The staff made an alternative recommendation that we reduce the budget from UVM further so that the additional 16 million that was going to be transferred out of the medical center was not there to be transferred.
Okay. Well, I don't know what that means, but interesting. One of the things, just a factoid that nobody pays any attention to, the UVM Health Network has only been an integrated company since January 1 of this year, just so you know. Anyway, thank you.
Thank you for attending and for your comment, Mr. Davis. Mr. Bridges?
Thank you, Chair Foster. My name is Jesse Bridges. I'm the chair of the UVM Medical Center Board, and I do want to appreciate the comments from the committee. And I think, in particular, acknowledging, some of the unique dynamics that exist with regards to the governmental structure of the finances. Our board ultimately does not have the direct fiduciary oversight of the budget, but has weighed in significantly, and in particular over the last year, with particular comment around making sure that we've expressed our deep desire for compliant budgets and budgets that reflect both our desire for continued climb in our quality, which is increasing, continued climb in our access, which is directly related to our staff satisfaction and ability to do that work. I round with Dr. Leffler regularly, and I can tell you that the efforts of our local leaders are making a difference. The quality on our floors, the retention on our floors, the staff satisfaction, the results are improving. And I know that's what we all are here for, and that's what we all care about. And we know that alongside that, the affordability piece has to move, and we've got to do that work alongside you. And I know as we sat over the last year working hand in hand at some of the issues from previous year budgets, I think you know that our volunteer boards are working hard to do their best to make sure that we are pulling and pushing in the right direction. And I will let the board know that and the community know that the UVM Medical Center Board will continue to do this work, and we take renewed focus on the points that you have made today and the presentation that you've made today. I will make sure that all of our board members are up to speed on what you have presented, and I know that we will have some further thoughts and work to do in the future. Thank you.
Thank you. And thank you for your work, Mr. Bridges. And my view is I think the medical center board members need additional support. There's just not enough resources for the level of work and complexity that you have to deal with. Mr. Fisher?
Thank you, Mr. Chair, and thank you all 5 board members. It would be pretty tricky for me to try and add to what you've said without repeating. I don't want to repeat what's been said, though I probably will just a little bit. I guess I want to join in expressing a level of outrage about where we find ourselves. Yes, some of the most expensive costs in the country, and a system that is incredibly unstable at this moment. Yes, affordability for Vermonters as they try and seek care and buy coverage, and yes, a system of delivery that is teetering, that is at real risk. Exactly what happens in the coming weeks in DC will have a huge impact on just how hard this lands on many Vermonters seeking to buy coverage with regard to premium tax credits. We find ourselves in a really very, very tricky place. One heartening thing, I go back a year ago. Well, what's different today than a year ago? I recognize all 5 board members expressing a level of I'll say a level of outrage, maybe that's my word, about where we find ourselves. I also recognize that we have the Commissioner of the Department of Financial Regulation weighing in, saying that he and his office will do what it can in the back end of the system, and recognize that the governor also made an incredibly strong statement in support of the board's work and in recognition of the challenge that we're all facing right now. I both want to recognize that and appreciate that the board members are doing, you will do what you feel you can. And I recognize that. As the advocate, I would call on you to do more. The Healthcare Advocates Office recommended a larger cut to UVM in recognition of all of the case that has been laid out so clearly here. And then lastly, only so much can be done at this table, and more work will need to be done. And as I said, you know what? I forgot a major party when I mentioned who was on speaking the same tune. The legislature too spoke out and acted in an incredible way to recognize this challenge and do what it felt it could last year. So we have more work to do to make sure that we fix the problems in front of us and reduce the costs. Appreciate your work. Thank you.
Thank you. Any other public comment? Okay. There's a couple conditions, a couple motion changes that were recommended. And so I want to just take a brief break to get this all in one concise slide so that we can consider it. So I'll take a 10-minute break, recess to 2:36 so we can accommodate the board members' requests. All right, thank you. A brief recess. We can go back on the record.
Okay, we're on the record.
Great, thank you. Mr. Slutter, could you pull up the slides? Okay, I'm going to withdraw my motion, given some of the information that has come about and Ms. Teachout's proposal. So first, I am going to include, I'm going to make another motion. I'm going to make it including this condition, the consistent accounting condition. You can go to the next slide, Matt. I'm going to make the motion with rate condition option number 2 that Ms. Teachout indicated she preferred, where it allows UVM the flexibility to have lower prices in outpatient and have some negotiations with insurers to account for that and give it some of the flexibility that it indicated it needs, while at the same time balancing the need to contain costs and prevent the extremely high costs that end up being borne by the insurer. And then this is part of option 2, and then you can go to the next slide. In the next slide, Matt. And then this will be the motion. The motion has been changed slightly. So again, it's the accounting condition. It's the lower outpatient pricing and negotiation piece that Ms. Teachout wanted. And then third, it reduces the $16 million in budgeted money to be transferred to New York. So it's a reduction of the margin and a reduction of the $16 million that was budgeted to be transferred to New York. And the rationale for that is it's not clear that the medical center will agree to not transfer the money. And the legal department has indicated it believes we do not have the authority to make an order that prohibits them from making those transfers. However, I will say that if the medical center does not transfer the money and would like to come before the board for a mid-year adjustment to add back in the 16 million, I would encourage it to do so. If some of the board members' stated concerns are addressed and the medical center wants to apply for that $16 million back in a mid-year adjustment, I would be very welcome to reviewing that and encourage the medical center to apply for it if it does not transfer the funds to the New York hospitals and instead keeps them here or reduces costs. So I'll go ahead and make the motion. I move to approve the University of Vermont Medical Center's budget with the following modifications. Total NPR approved at not more than minus 0.2% below fiscal year 25 approved budget, with a total NPR of not more than $1,898,078,939. Commercial NPR approved at not more than $1,068,914,992. Commercial reimbursement rate reduced by at least 6.4% over current approved levels, subject to the following conditions reviewed by this board. 1, the consistent accounting condition. 2, the rate condition targeting outpatient rate reductions, which we called option 2. And 3, the charge condition targeting reductions to outpatient charges, option 2. And lastly, subject to all other standard budget conditions as approved by this board.
I'll second that.
Any further discussion by the board members? Any additional public comment? Hearing none, all in favor, please say aye.
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 Aye. And the motion carries. Thank you very much, Mr. Sutter and your team and Mr. Henksler for your work. Next on the agenda, we have the Northwestern Medical Center's budget.
Give me one moment, Chair Foster, and I'll pull those up. Sorry, Chair Foster, did you want to go with Northwestern first? I may have misheard what you said.
Oh, no, it doesn't matter to me. I think the order is just fine. My sense from the staff recommendation was that most board members were generally supportive. I'm going to make the motion and we can have a deliberation. I move to approve Southwestern Vermont's Medical Center budget with the following modifications. Total NPR approved at not more than 3.5% over fiscal year 25 approved budget with a total NPR of not more than $218,054,234. Commercial NPR approved at not more than $99,253,903. Commercial reimbursement rate approved at not more than 5.2% over current approved levels. Subject to a mid-year adjustment should SVMC receive a favorable 340B determination, and subject to all other standard conditions, budget conditions as approved by this board.
I'll second.
And is there any, I support the motion, I made it, and I'll open up to others.
I'll just jump in again. I supported option number 2. And the reasons are, hold on one second.
Mr. Site, can you pull up option 2 if you have it available while Ms. Teachout speaks?
Sure. So Vermonters with commercial health insurance coverage cannot continue to cover hospital shortfalls. This is not about the SVMC operations, but it's about the financial pressure on families and employers. I think it's troubling to approve significant increases to commercial rates now in order to cover potential future losses next year that have not yet been verified, even though I understand that it may be likely. And it's especially irksome that the 340B program that generates hospital revenue on the margin between discounted drugs and higher prices charged to commercial patients with private health insurance is the reason for this extra increase. This is perpetuating the dysfunction in our healthcare system. So I prefer option 2, but I don't know where the other board members stand.
I can jump in quick. I also preferred option 2. Similar reasons. The timing. This is approving an increase because of something we think may happen, even though it's likely. I'd rather they SBMC come back if needed when this does happen. So that's all.
And Member Merman?
I find this one challenging. I do support option 2 over option 1, which I think has the risk that if it happens, which it sounds likely that it could create, a higher commercial price request than we would get now because it would be focused on a shorter period of time. But I also think there may be opportunity to improve efficiency and figure out other ways to make up that revenue, that having the stress of that might motivate, so that if they do come back, we may not see the need to improve that large of an increase. So that's where I stand.
Okay, thank you. I completely respect those opinions. This is a hard one. I will withdraw my motion, as it sounds as though there are likely 3 votes for option 2. So my motion is withdrawn if someone wants to make a motion on option 2.
I'll jump in and go ahead and move option 2. And I believe that option 2 does allow the hospital to come in with a budget adjustment request after they find out for sure the ramifications of their 340B program.
Second.
Any additional board member discussion? I'll turn to the healthcare advocate.
Thank you, Chair Foster. We also support option 2. Thank you.
And I'll open it up to public comment. Mr. Hengstler, could I ask you to take a roll call vote, please?
Yep, so this is a roll call vote on member Teachout's motion for option 2, which is up on the slide deck right now. I will start with member Holmes.
I'm a no. I preferred option 1.
Member Merman.
Yes.
Member Teachout.
Yes.
Member Walsh.
Yes.
And Chair Foster.
No.
Motion carries.
Thank you. And we will move to Rutland Regional Medical Center. I move to approve Rutland Regional Medical Center's budget as submitted, with total NPR approved at not more than minus 2.5% over fiscal year 25 approved budget, with a total NPR of not more than $336,642,584. Commercial NPR approved at not more than $165,151,422. Commercial reimbursement rate approved at not more than 1.5% over current approved levels, with payer-specific rates approved at not more than the figures presented in Rutland Regional Medical Center's proposed budget, and subject to all other standard budget conditions as approved by this board.
I'll second.
And board member discussion?
A brief point on this one. I do have some concern about a budgeted negative margin. I think it's I appreciate the attempt to make this work, and I wish them the best of luck and hope it ends up being a positive margin. But I do have some concerns.
Healthcare advocate?
We support the recommendation. Thank you.
Public comment? All in favor of the motion, say aye.
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 Aye. The motion carries. Northwestern Medical Center. I move to approve Northwestern Medical Center's budget as submitted, with total NPR approved at not more than minus 2% over fiscal year 25 approved budget, with a total NPR of not more than $130,887,475. Commercial NPR approved at not more than $83,700,251. Commercial reimbursement rate approved at not more than 2.65% over current approved levels, and subject to all other standard budget conditions as approved by this board.
I'll second.
Board discussion? Healthcare advocate?
We support the recommendation. Thanks.
Public comment? All in favor, say aye.
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 Aye. Motion carries. Manascutney. I move to approve Manascutney's budget as submitted, with total NPR approved at not more than 3.5% over fiscal year 25 approved budget, with a total NPR of not more than $75,343,734. Commercial NPR approved at not more than $25,402,822. Commercial reimbursement rate approved at not more than 3% over current approved levels, and subject to all other standard budget conditions as approved by the board.
Second.
Any board member deliberation or discussion? Healthcare advocate?
We support the recommendation. Thank you.
Thank you. And public comment? All in favor of the motion, say aye.
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 Aye. Motion carries. Springfield Hospital. I move to approve Springfield Hospital's budget as submitted, with total NPR approved at not more than 8.3% over fiscal year 25 approved budget, with a total NPR of not more than $69,804,489. Commercial NPR approved at not more than $33,449,140. Commercial reimbursement rate approved at not more than 3% over current approved levels, subject to all other standard budget conditions as approved by this board.
Second.
Discussion? Healthcare advocate?
We support this. Thank you.
Public comment? All in favor, say aye.
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 Aye. The motion carries unanimously. Gifford Medical Center. I move to approve Gifford's budget as submitted, with total NPR approved at not more than minus 2.5% over fiscal year 25 approved budget, with a total NPR of not more than $65,060,532. Commercial NPR approved at not more than $29,175,160. Commercial reimbursement rate approved at not more than 3% over current approved levels, subject to all other standard budget conditions as approved by this board.
Second.
Discussion? Healthcare advocate?
We support this. Thank you.
Public comment? All in favor, say aye.
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 Aye. Motion carries unanimously. Is that all of them, Mr. Sutter?
That's all of them. Yes, sir.
Great, okay. Is there any other new or old business for the board? Oh, wait, there is old business, I'm sorry. Actually, I don't know what that is. I'll skip that. Any other old or new business for the board? Okay, great. It is important to recognize the tremendous effort that our health systems finance and legal team and staff, including a whole number, everybody, that puts this all together and reviews all of these budgets. I was getting emails last night at 1 a.m. from a staff member and others at 6 a.m. today, and that is not an exception. They do that the entire hospital budget season. They work tremendously hard and they demand incredible respect. And I want to thank them and appreciate their contributions to public service into the state in one of the thorniest and hardest issues the state is battling right now. So thank you all very, very much for your efforts. Additionally, I did want to recognize that this also creates a significant burden in time on many of Vermont's hospitals and the providers, I'm sorry, the administrators mostly that prepare and work on the budgets and work with our staff. A number of hospitals are extremely wonderful to work with and helpful, and it's very collaborative. And I really appreciate hospitals recognizing we have a limited staff and they're trying to do their best. And we also thank you all for, there's a number of hospitals with very reasonable and fair budgets. I wanted to call out a couple that reduced and had negative margins this year. They booked negative margins and were planning to draw on their reserves. And I think that really speaks to their recognition of their community's problems and challenges with healthcare affordability. I think that deserves special call out, that we respected that and appreciated it. And I had nothing else other than appreciation for all of the public that makes time to come here and read a lot of this material and comment. We read every single one, and it is often far more influential than you may think. And lastly, the healthcare advocate. They provide insightful analysis and thoughts on so many budgets, and I read those very closely. And I know that you all work exceedingly hard. It's a very, very talented office. So I appreciate that effort as well. And with that, I will move that we adjourn.
Thank you.
Second.
All in favor, say aye.
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 Aye. We are adjourned. Thank you.